Today we're going to be talking about cyclosporine. This drug, while initially investigated as an antifungal antibiotic, has changed the face of organ transplantation due to its immunosuppressive activity. But first, let's take a step back. What is cyclosporine? Cyclosporine was originally discovered in 1971 by a man who put a soil sample in a plastic bag while he was on vacation. This was done as a tradition as part of a program set up in 1957 by Sandoz Limited, a Swiss pharmaceutical company. Sandoz employees were given plastic bags for collecting soil samples while on business trips or holidays. When they returned, the soil samples were cataloged and screened. The purpose of this program was to search for new antibiotic drugs from fungal metabolites abroad. At the microbiology department at Sandoz Limited, a fungus Typhlocladium inflatum was isolated by B. Thiel from two soil samples, one taken from Wisconsin, USA, and the second from Hardanger Vita in Norway. This fungal peptide was the first immunosuppressant that acted selectively to suppress T-cell immunity. Organ transplants in Canada have risen about 23% over the last decade, but organ rejection, which is an adaptive response by the body's immune system, remains one of the biggest hurdles to successful transplantation. This immune response is carried out by killer T cells who induce programmed cell death or apoptosis of target cells that make up the tissue graft or transplanted organ. Since 1961, the standard method of treatment for achieving immunosuppression has been a mix of azathioprine and corticosteroids. Azathioprine inhibits cell proliferation non-selectively. However, its main unwanted side effect is depression of the bone marrow. Other toxic effects include a mild hepatotoxicity, skin eruptions, nausea, vomiting, and lung infections. Cyclosporine's immunosuppressant effects were discovered by J.F. Borel. It was the strongest immunosuppressor at the time of its discovery. It also overcame many of the risk factors associated with azathioprine and is relatively non-toxic to bone marrow. Further animal trials showed that cyclosporine selectively inhibited the proliferation of lymphocytes by acting on an unknown and unique step in the process, but proliferation of somatic cells remained unaffected. In the words of Borel, it was almost too beautiful to be true. With the introduction of cyclosporine, patient morbidity fell. It became possible to transplant organs with a 1-year success rate 20% higher than previously done. And it became possible to transplant organs successfully, which previously had only been done in experimentation. Today, cyclosporine is presently approved for use in organ transplantation to prevent graft rejection in kidney, liver, heart, lung, and combined heart-lung transplants. Pharmacology and toxicology of cyclosporine. Cyclosporine is typically administered in two ways, through IV or oral administration. When switching from the oral route to the IV route, the oral dose is multiplied by 3 as the bioavailability of it is only about 30%. Following oral administration, the absorption of cyclosporine is incomplete, and the extent of the absorption is dependent on the individual patient and the formulation. Absorption occurs mainly in the small intestine and is typically poor as a result of the first-pass metabolism, making its bioavailability low and variable. In addition, food also alters the absorption of cyclosporine, causing a decrease in the area under the curve, Cmax, and an increase in the typical half-life of 8.5 hours. Following absorption, the xenobiotic is distributed throughout the body, largely outside the blood volume. Since it is lipophilic, approximately 90% is bound to proteins, primarily lipoproteins, within the plasma. At high concentrations, the binding capacity becomes saturated. Once the xenobiotic reaches its targets, it acts by preventing white blood cells from attacking the transplanted organ, as the body typically views it as a foreign invader. Upon entering systemic circulation, it binds extensively to erythrocytes, and only the unbound drug is capable of entering lymphocytes and exerting its immunosuppressive effects. Cyclosporine has an overall suppressive effect on cell-mediated and humoral immune responses. Once it reaches the target cells, it can easily cross the membranes due to its lipophilic nature. Inside the target cells, it binds with high affinity to cyclophilins, a family of cytoplasmic proteins that are present in most cells. This drug receptor complex specifically and competitively binds to and inhibits calcinurium, a calcium and calmodulin-dependent phosphatase. This process inhibits the translocation of a family of transcription factors, which leads to deduced transcription of cytokine genes, for example, interleukin-2, TNF-alpha, and IL-3. As a result, there is a significant reduction in the proliferation of T lymphocytes, with T helper cells being the main target. The immunosuppressive properties of cyclosporine helps to prevent organ rejection, typically for kidney, heart, or liver transplants. As it follows its course throughout the body, cyclosporine is extensively metabolized by CYP3A4 enzymes in the liver. In addition, there is some metabolism that occurs in the GI tract and the kidney, but to a lesser extent. The CYP3A4 enzyme is considered the most prevalent cytochrome P450 enzyme in the liver and is responsible for the metabolism of 40 to 70% of all xenobiotics. Taking cyclosporine in combination with CYP3A4 inhibitors such as erythromycin, oral contraceptives, and grapefruit lead to an increase in cyclosporine concentration because they decrease metabolism. On the other hand, CYP3A4 inducers such as garlic supplement St. John's wort, and rifampin lead to a decrease in cyclosporine concentration by increasing metabolism. Altering the concentration of the xenobiotic can lead to serious side effects such as kidney toxicity, liver toxicity, and nervous system effects. Ultimately, it changes the relative bioavailability of the xenobiotic, which will have significant impacts on its effectiveness within the body. For example, taking a CYP3A4 inducer with cyclosporine leads to a decrease in the plasma concentration and a decrease in the half-life of the parent substance. The concentration of the drug is significantly reduced since its biotransformation is stimulated. This results in greater elimination of the xenobiotic from the body and ultimately a reduction in its effectiveness, which could cause the body to reject the transplanted organ. As a result of the cyclosporine metabolism, there have been around 25 metabolites identified whose toxicity and biological activity have been found to be considerably less than those of the parent compound. Finally, the xenobiotic and its metabolites are excreted from the body. Elimination is primarily biliary, with only 6% of the dose excreted in the urine. Due to the substantial metabolism of the substance by the CYP3A4 enzymes, there is only about 0.1% of the original dose that is excreted unchanged in the urine. What are the implications of cyclosporine? Cyclosporine falls into the immunosuppressant drug category, meaning that the drug targets and weakens our immune system. The desired effect is used for, but not limited to, the treatment of rheumatoid arthritis, psoriasis, and mainly the prevention of organ transplant rejection. The risk of life-threatening conditions and very severe infections increases drastically if an individual suffers from any type of cancer, kidney conditions such as chronic kidney disease or acute kidney injury, persistent or non-treated high blood pressure, or has had previous radiation treatments for psoriasis. If the patient suffers from any of the given conditions, they may be advised against the use of the drug or not even given a prescription. The drug, even with its overall positive therapeutic use, does contain many side effects, making the monitoring of the drug dosage essential. When taking the drug, one may exhibit typical minor side effects, which tend to be stomach pain, bloody gums, skin blemishes, acne, sensitivity around the eye area of the face, or typical cold symptoms. But there are major side effects too, like renal insufficiency caused by reduction of blood flow to the kidneys that potentially causes nephrotoxicity. This goes hand in hand with the hypertension that the drug may also cause. The drug's price is directly related to the high degree of efficacy. Since the drug is efficient at its job, the cost of the drug at the pharmacy remains high. The drug cost varies depending on dosage, but for someone who has undergone a transplant, they would be paying around $61,000 annually for the immunosuppression therapy. The reason the price of the drug is held at this high price is because the efficacy leads to lower hospitalization rates and charges within the first year of transplant. Long-term cost effects have not been very well developed due to a majority of patients' bodies accepting the organ within the first year. And these are the future outlooks for cyclosporine. Those who are most affected by this drug are those who have undergone organ transplantation. Those who are at risk include the recipient of the organ, and especially those with renal failure issues, hepatic issues, and even nervous system issues. As mentioned earlier, despite its benefits, cyclosporine has some adverse effects, such as being less cytotoxic than most calcinurium inhibitors, also known as CNIs. Nephrotoxicity is a well-known side effect, probably induced by the vasoconstrictive effect of cyclosporine. Looking to the future, long-term consequences of cyclosporine therapy and innovative treatment protocols will define the size of the role cyclosporine will play in the future, as well as the interaction with highly presensitized patients. Double induction with basiliximab and low-dose thymoglobulin could be a step forward towards minimization of early immunosuppression, especially in the early postoperative critical period. Basiliximab is an immunosuppressant agent used to prevent immediate transplant rejection in people who are receiving kidney transplants. Thymoglobulin is an immune globulin. It works by suppressing the body's immune system response, but the way it does so is not fully understood. Also, new strategies to reduce cyclosporin nephrotoxicity have been recently proposed, as the experimental use of either erythropoietin or carb-amylated erythropoietin to reduce cyclosporin tubular apoptosis, interstitial fibrosis, and macrophage infiltration. However, whether this can be applicable to humans and in which grade it would change the immunosuppressive ability of cyclosporin is not known. A new and upcoming drug for post-transplantation treatment is tacrolimus. It is a once-daily prolonged-release formula and has become a natural first choice instead of cyclosporin because of its higher potency and its significantly lower rate of acute rejection. In terms of adverse effects when compared to cyclosporin, tacrolimus has a favorable profile in terms of cardiovascular risk factors such as hyperlipidemia and hypertension. However, tacrolimus increases the risk of hyperglycemia and the development of onset post-transplant diabetes more so than cyclosporin.